Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Julie Woodward. Dr. Woodward is a professor of ophthalmology, an associate professor of dermatology, and chief of oculofacial surgery at Duke University Medical Center. Dr. Woodward, thank you so much for joining me today.
Thank you, Dr. Ball, so much for having me. I'm excited to be a part of the Pupil Pod.
Yes, well, we're excited to have you here. So we'll jump right into the case. We have a 55-year-old man presenting with uncontrollable twitching of the face. When you enter the room, you notice unilateral right-sided mid-face spasms. Now, Dr. Woodward, how would you approach the early workup of a patient that presents to you like this?
Well, the first thing that I would do with a patient like this is get some history. I would try to figure out about how long this has been going on. I would ask him a few questions, such as he's a little bit on the older side for pure hemifacial spasm. You wonder, could this be starting as blepharospasm? Because a blepharospasm patient tends to be a little bit more about this age. So he's kind of in between, but I would ask him if he's absolutely sure this is always on one side of his face, because oftentimes I'll see blepharospasm presenting on one eye, but it will eventually spread to the other eye. So that's not uncommon, at least in my experience. So I'd ask him first if it's on definitely on one side. If it's not on the other side, I'd be leaning more towards hemifacial spasm. And then the next questions I would start to ask is if it wakes him up at night, because if he occasionally wakes up in the middle of the night twitching, it's much more likely that it's hemifacial spasm than blepharospasm, which can go away at night. So those questions are very important to try to figure out what's going on. Then I would consider some typical questions like family history. Are there any family history of twitching, writer's, tremors, essential tremors, Parkinson's disease? Because all those genetic type things tend to be on a spectrum with blepharospasm, whereas hemifacial spasm tends to be more mechanical, as you know. That tends to be due to a vertebral artery that's making a little extra curlicue loop that's tickling on the seventh cranial nerve and making them twitch on just one side. So it's much more of a mechanical thing than it is a global brain condition. So that's how I would start.
It's so important to ask about family history too. I think sometimes in ophthalmology, we kind of overlook that, right? We're like, oh, what's your history? What's your eye history? But always asking that family history is so critical. So let's say you get a really good history. What kind of other physical exam findings would you look for? You kind of alluded towards bilateral versus unilateral. Is there anything else specifically that we need to be aware of?
Absolutely. Then I would ask a little bit more about their health history. I would ask if they've had any kind of a trauma, because any type of trauma could cause nerve injury that could cause unilateral twitching. I've seen two patients in my clinic have hemifacial spasm from Guillain-Barré. So I'd ask them if they've ever had Guillain-Barré, either from the flu or from a vaccination, for sure. And another thing that can mimic hemifacial spasm is multiple sclerosis. So again, ask them other symptoms of multiple sclerosis. If they ever had an episode of optic neuritis, do they have a neurologist that sent them over because they have MS? Very rarely vitamin A deficiency. I've never actually seen that in a patient, but I have seen MS and Guillain-Barré mimic hemifacial spasm. So there's a couple things to think about.
Oh, that's a great pearl. I never think of GBS for that, but now I will. I definitely will. I hadn't heard that before.
Yep, I have patients that have had that.
Wow, that's fascinating. I mean, it is the ascending paralysis is pretty tough for patients to deal with. So just add one more thing to the bucket for them to have to deal with. It's unfortunate.
More unusual causes. But then if I'm starting to narrow it down to think, okay, this is the mid-face twitching, it's not really isolated around the eye, I'm pretty sure that it's hemifacial spasm, and they haven't had a trauma or anything like that, then it's time to start talking about getting an MRI, MRA. So I go ahead and get those ordered, and you have to specifically ask the radiologist for imaging of the cerebellopontine angle, as you know, because if you don't request it, they probably won't image that area closely enough. You can ask for, imaging of the seventh cranial nerve, but it is pretty important to go ahead and ask them for exactly the area that you're looking for. And that's to rule out a tumor that could be tickling against that nerve. It's almost always, though, the vertebral artery tickling in that little curlicue.
And no, that's another really important pearl is when we're asking for very specific causes for our neuroimaging, it is important to give our radiology colleagues a heads up and let them know exactly what part of the anatomy we're looking for and exactly what we're hoping to find or what we're expecting to find, because they too are scanning this really complex neuroimaging that they don't necessarily always get that tiny minutia, and it's easy to miss if we don't ask for it. So as trainees, it's always really important to remember that. So, switching gears just a little bit here, let's say that this patient didn't have hemifacial spasm, but instead had blepharospasm. Is there a way that you can kind of distinguish blepharospasm from just run of the mill eyelid myokymia?
Yeah, another good question. So, myokymias tend to be more minor, little fleeting twitches. Patients have a little anxiety about it. You can assure them that usually it goes away in a couple of months, 2 to 3 months. They may still enjoy a little dot of Botox to be able to just stop it, temporize it until it goes away. They're often triggered by stress, caffeine, things like that. And sometimes people believe it's low potassium, so you can have them eat a banana, and assure them that this will get better. Blepharospasm is obviously much more debilitating. It can start in one eye, so it can mimic a myokymia, but eventually it spreads to both eyes. And like I said, there's oftentimes some family history back there, even if it's an aunt or uncle. I have a lot of patients who have a sibling that has it or a parent that has it. I've seen all that over the years. Um, and blepharospasm, the frustrating thing about it is it can hit like a Mack truck. It could be like their life is fine, and then some stressful incident just triggers this, and it's life altering. As you know, a lot of these patients come in and they're functionally blind. They can't drive. The tough thing about blepharospasm is that when the patient is speaking, they're having what's called a sensory trick. And the act of speaking, and sometimes speaking louder and louder, suppresses the spasm. So they have other sensory tricks that they can have as well, such as sticking out their tongue, humming, singing. Ask them if it gets better when they're in the car. If they sing a song, they'll be like, oh, yeah, I do kind of hum when I'm in the car. That makes it a little bit better. Some of them pinch their skin or twiddle their thumbs. All those little sensory tricks suppress the spasm, including speaking. And that's why blepharospasm patients end up in 8 different doctor's offices on average before they actually make it to someone who's prepared to treat them properly. And they are usually kind of angry at this big list of doctors that they've seen that have misdiagnosed them with all these different conditions. And I always tell them, it's typical. The average person has been to, so it kind of calms them down, makes them trust you, like you understand what's going on a little bit more, and then you can proceed with discussing therapies with them.
It's so sad that, we still, it's no one's fault, right? It's not doctor's fault, it's not the patient's fault, but we just don't there's so much we don't understand about so much pathology that a lot of this gets overlooked. Okay, so let's say that you have diagnosed your patient with hemifacial spasm. How would you treat that patient versus eyelid myokymia versus blepharospasm? Kind of, how do you think about the differences in treatment? Do you have non invasive versus invasive? Kind of, can you walk us through some of those pearls?
Absolutely. So everybody knows that the treatment that works the best is botulinum toxin. That's what's going to work the best. Usually the myokymia, unless it's been persisting for a couple of months, 2 or 3 months, we usually don't treat them. We give them just reassure them, minimize caffeine, little stress management, maybe a little bit of Botox. Problem is it's difficult to get on insurance. It may be something that they have to do as a cosmetic treatment. But if we really think that they have hemifacial spasm and they have a negative MRI, or the MRI confirms that that vertebral artery is tickling that nerve, we usually discuss with them what's going on so they understand the anatomy. And I always give them the option of surgery, even though I think I've only had one patient ever opt to have surgery. The neurosurgeons are very comfortable, especially the ones I've worked with an operation called the Genu operation, where they wrap the seventh cranial nerve away from the vertebral artery with a little sponge. It's called the Genu operation. Uh, Almost always patients would rather have Botox than brain surgery. Some insurance companies and Medicare may require that they fail an oral medication before you can give them botulinum toxin. So we may give them something like a benzodiazepine, Klonopin, sometimes a muscle relaxant such as baclofen, less likely anticholinergic drugs. And once you can document that they failed a trial of those, then you can go to an injection of botulinum toxin. And sometimes you have to think with the insurance companies, what is FDA approved for hemifacial spasm? And so we know that Botox is approved. There's other treatments that are not FDA approved that insurance companies may give compassionate care if they want to try it, or some insurance companies prefer you use a non FDA approved product because it may be less expensive or it's what's on their formulary. So we talk to the patient about that, get their approvals, and bring them back. When you start thinking about injecting a blepharospasm patient versus a hemifacial spasm patient, it's important to realize that hemifacial spasm patients tend to be much more sensitive to the Botox or botulinum toxin. And so they may need less, and they may be more apt to have dry eye afterwards. So they may be so sensitive to it that they can't close their eye as well. So the injection pattern's a little bit different, perhaps a little bit lighter on the pretarsal orbicularis muscle, and then we still inject the lateral orbicularis or lateral canthal lines. We do the nasalis muscle, and of course, the corrugator muscle and the procerus muscle on that side. The thing to watch out for to minimize complications with a hemifacial spasm patient or a blepharospasm patient is to avoid ptosis. If you inject too high when you're injecting the corrugator, it will spread into the frontalis muscle and you get a brow ptosis. Some injectors don't understand the difference between getting a brow ptosis because they can't lift their frontalis muscle and a true eyelid ptosis. Eyelid ptosis usually does not come from injecting too much right on the eyelid itself. It's very difficult for the toxin to pass the orbital septum. Where the injection causes ptosis, we actually published a paper on this in Plastic and Reconstructive Surgery. And there's a recent paper by Dr. Cotofana, kind of dovetailing on some of the ideas from this. If you inject right over the supraorbital bundle, you may nick the artery or the vein, and you put a little bubble of neuromodulator right there, and then it bleeds because you nick the artery or the vein. What do? You put pressure on it, and that little bubble of toxin will catch on the nerve sheath, which is a potential plane, and zip right along it. And that nerve, the supraorbital nerve, runs right on top of the levator muscle. So we did a study in cadavers where we injected methylene blue dye a whole centimeter above the brow. Granted, we gave a good dose, like a half a cc, but it made it all the way along that nerve to the apex of the orbit when we dissected off the roof of the orbit. So it can absolutely track along that nerve path. So that's the one place to watch out for to avoid ptosis.
Wow, I had not read that paper, so I'm learning something new as well. So, are we saying don't put any pressure in case there were a nicked artery there?
Usually I palpate it to know where
Okay.
the notch is, and then I'll just make sure to stay a little bit medial and a little bit lateral to it, so I have a less likely chance of toxin getting next to that nerve.
Okay, interesting. Okay, I'm gonna start doing that in my practice too.
That was the old teaching when Botox was first approved way back in, was it 2003? The ptosis rate was published at 5 point something percent. Then a few years later, when Dysport was approved for cosmetic use, it was the ptosis rate went down to 2.2%. And then when incobotulinum, which is Xeomin, was approved, the ptosis rate went down to 0.2%. And that's not really because the toxin caused less ptosis, it's because injectors, particularly the dermatologists that aren't as used to the anatomy, they learn not to go to bone to feel the bone and then pull back to guess where the muscle is. They learn to float it a little bit better and to protect the orbit as you're doing the injection.
Okay, okay, that's great to know. So, what are some of the other complications that we can have from using Botox for these patients? Are there any other complications that you think about when you counsel them for the neurotoxins?
Yeah, just those are the main things. Just not, realizing they might be a little more sensitive, which is a plus and a minus. If you inject a little too much, they may complain about being very dry. I had a patient recently come up who was so sensitive he couldn't close his eye for a few weeks and had to tape it shut and was kind of frustrated. But the good thing is it always wears off. That's the good thing.
Hmm.
So there's very little risk with toxin other than injecting it so frequently that they get antibodies. Now, the other thing that's nice about hemifacial spasm is the toxin, because they are more sensitive, it does tend to last longer. So I have some hemifacial spasm patients that need their injection every 3 months, but a lot of my patients can go 5 months, sometimes six. They are happy to get it just two, maybe three times a year because it just lasts longer. Blepharospasm patient, it always wears off. They're always miserable at 8 to 10 weeks. They're ready for more injections at 8 to 10 weeks. And then that's when we sort of temporize them that last couple of weeks until their insurance will pick it up again with oral medications. So with blepharospasm patients, they may be sensitive to the Klonopin that helps them a lot, which is a sedative. Unfortunately, the side effect is it makes them drowsy. Some of these patients like to be subdued a little bit because blepharospasm patients tend to be very type A, they're kind of go-getters. Uh, the other medication that we actually published a study on for blepharospasm is Ritalin, so methylphenidate. We did a study with patients where we video recorded their eyes without Ritalin, and then we also had them connected to an EMG machine, and we could see where the voltage of their spasm was. Their eyes were tight, the voltage was high, and then we gave them Ritalin, and 30 minutes later, their eyes were open, their
Oh,
chin was in a
wow.
better position, and the voltage was low. So yeah, we presented that. Patients can actually see that on the BEB. I'm on the medical board for the BEBRF, along with some other oculofacial surgeons and some neurologists that are amazing to work with. And anyway, that lecture's on their website.
It's so fascinating because it's kind of an opposite mechanism to the benzodiazepines, but it's also working for the same thing. So that's really fascinating.
It's amazing. We're not exactly sure why it works. It may be because it's dopamine mediated. The neurologists
Mhm,
aren't
mhm.
sure. We just, had it. I presented it in front of four neurologists and a neurosurgeon recently, and they even agreed that it works. It's like I said, we're not exactly sure why any of these medicines work, but you name it. If anything, if there's a pill on the market or an eye drop that's available, it has been tried in blepharospasm, including the rose tinted glasses, the 141 glasses, and nothing seems to ever cure blepharospasm. I think one of the best things is surgical myectomy or neurectomy. I do that procedure, and patients absolutely love it. It's nearly always successful. I think I've done so many, and I think I've only had two patients. I never had anyone say they regretted it ever. I've had two patients say it didn't really help that much, but the vast majority are say it's absolutely life changing.
And can you walk us through that just a little bit, what that entails?
Yeah, and I can do that procedure for both hemifacial spasm and benign essential blepharospasm. We just do it a little bit more gently with hemifacial spasm, but with blepharospasm, I do all my surgery with the CO2 laser, so it bleeds very little. The pioneer of it was Rick Anderson, who was from Utah, and he's an amazing surgeon. He did a very extensive myectomy, taking out the corrugator muscles and all. And actually, our neurologist that worked at Duke for a while, who's went on to be a chancellor, and he wrote the book on dystonia. Literally wrote the book on dystonia. He was pulling my patients off of the schedule before he ever met me because he thought it was going to be a surgery that was a bloody mess. And then he heard me give a presentation on some of my videos of doing it with the laser, and he was so excited he sent me patients for the rest of his career at Duke, and we worked extremely well together. So I do the procedure with the laser. We do a blepharoplasty. I tend to leave the eyelid crease a little high in anticipation that the tissue over the tarsal plate may contract a little bit. And we use a laser to undermine the skin away from the pretarsal and preseptal orbicularis. We take care to take out the orbicularis and the small nerves that are creating the blink response from the seventh cranial nerve that travel along the angular artery to come up medially. And then we make sure to get the lateral branches along with that muscle as they're coming up laterally. The more powerful part of the blink reflex is actually coming from medial, those medial nerves that kind of swing around the orbit, and a little bit lesser power is coming from lateral. So it's a neurectomy, myectomy all at once. We have to warn the patients about dry eyes. We usually lift their levator just a little bit because almost all of them have ripped it out with their spasms by that point, and warn them they may be a little dry for a while. I had a patient come in today. She actually flew in on a private jet. She was referred from another state and was so thrilled. Her eyes a little dry, but she says she had not been able to drive for 18 months. And now she says she can do everything in life that she couldn't do before. And she's absolutely thrilled at the price of just taping her eye, one of her eyes shut a little bit at night.
That's incredible. That's incredible. I mean, there you have it. We may not understand fully why some of the things that we do work, but we do have all of these different technologies in our armamentarium that we can offer to our patients. So it's really incredible.
Can I talk briefly a couple minutes about upcoming toxins? Because that's the exciting part.
Yes, yes, tell us, please.
A lot of people don't realize that we have 9 neurotoxins soon to be on the market. People think, oh, we just have 3. We just have Botox, Xeomin, Dysport. No, we've got a whole bunch. We have Onabotulinum, that's Botox. We have Avobotulinum, that's Dysport. We have Incobotulinum, that is Xeomin, which has less proteins. They all work a little different. Then we have Daxi. the Daxxify, which is only approved for aesthetic use. And then we have the Prabo, which is the Jeuveau, which is another competitor. And then we have one called Lativo, which is Letibotulinum. And that product was actually their factory got shut down by the FDA very briefly, but then they got their approval from the FDA. But they had kind of already laid off a lot of the workforce, so they haven't launched it yet. It just got purchased by another company called Benev, and so it's soon going to be launched as another available toxin. Then we have, of course, there's MyoBlock, which is botulinum toxin type B. Now we have two novel toxins coming out, which means that they're not the Hall strain. All those other toxins I mentioned, except for the B, are the Hall strain, the original strain that was cultured by our original, ophthalmologist from California, Alan Scott, who was a lovely gentleman. I absolutely love talking to him. There's two new ones. There's one coming out by Galderma called Relabotulinum, and it's going to be pre-constituted. They dug it out of the dirt. They found a brand new botulinum toxin A fresh out of the dirt that works slightly differently, and that's going to be launched pretty soon for glabellar lines and lateral canthal lines. And then there's a new one that's going to be launched by Allergan called Trenibotulinum, which is a toxin E. It's not going to be A or B. It'll be the first E, rapid acting, wears off quickly, good for people who aren't sure or scared of it. And it's supposedly going to be better for pain. So it may help with intermittent back pain. So it's pretty exciting to know that we have 9 toxins on the market. A lot of people don't know that at all, but it is up and coming.
I personally had no idea. And I'm hoping that having all of these toxins available will, number one, improve accessibility, right, for our patients. So we don't have to go through all these hurdles to get access, like, for example, having the PO treatments before we can do the injections. And also that we can treat a wider range, a bigger spectrum of pathology. It's
Right.
incredible. It really is.
And a lot of them now, like for example, the only 2 approved for blepharospasm are Botox and Xeomin. The Dysport is not even approved, and none are these other ones. They're all going to be cosmetic only. The Dysport's only approved for torticollis and chronic sialorrhea. But a lot of insurance companies prefer that you use these, and a clinical trial is up and coming to get the Dysport approved, which works very well. But it's still exciting. I mean, and there's topicals that there's a topical in China. Patients are begging for topical, especially on the thin eyelid tissue where they don't want to be stuck with a needle. So a lot of exciting research on the horizon.
That's amazing. Well, I look forward to seeing what new treatments we can offer our patients. And hopefully, we can schedule another podcast with you so we can talk a little bit about facial rejuvenation and kind of how this translates to the aesthetic side of things.
Oh, that's the fun and up and coming. And the new hot stuff is regenerative medicine. I'll be speaking at a regenerative medicine meeting in New York coming up soon. So I love my fillers and all these things, but there's new things coming there too.
Oh, that's incredible. Well, we'll definitely have to have you back on, something for us all to look forward to so that we can chat again about some of the new exciting stuff to look forward to. Dr. Woodward, thank you so much for joining us today on this episode of the Pupil Pod.
My pleasure. Take care.
And thank you to those tuning in. See you next time on the Pupil Pod.